Good morning, everyone. At the outset, I would like to thank Pooja ma'am for giving opportunity to present in this IC and the AIS for this virtual platform. This is an important topic for the day because fundus drawing helps in comparing the changes in pathology on follow-up visits, and it also helps our teammates and others to understand the pathology better. Just by giving a glance at the fundus photograph in a busy OPD can give us a lot of information. And there are various advantages associated with it, like it's less expensive than a fundus camera, and it at times it may be difficult to get all the information on the fundus camera because of the levels of lesion. So we can draw all the lesion beautifully in the fundus diagram, and it is also helpful in medical legal cases. With this brief, I would like to go further. The prerequisites are an examination table, an indirect ophthalmoscope, a 20 diopter lens, the various stationery like color pencils, an eraser, and a scleral depressor. Fundus charting is done on this chart, which is known as Amsler-Dubois chart, and it has got 3 circles. The innermost is the circle representing the equator. The second one is the ora serrata, that is the middle one, and the third one is the junction between the pars plana and the pars pliccata. We can see the Roman numericals here. It is nothing but to denote the extent and localization of the lesion, so in which clock hours the lesion is situated. When the fundus image is obtained as dealt by Dr. Vishal, it is seen inverted and laterally reversed. So to overcome this problem, we need to put the chart in which we are drawing the fundus diagram in the inverted manner. Like you can see here, the 6 o'clock has been put towards the patient's head and 12 o'clock towards the patient's feet end. So whatever we see in the quadrant, whichever we are examining, has to be drawn in the quadrant of the eye which is nearest to the. It should not be like you are seeing supratemporal quadrant and you are drawing it in the supratemporal quadrant again, because we have inverted the chart. So it has to be drawn in the infranasal quadrant, which is nearest to the examiner. And whatever, another thing to remember here is that the lesion which is in the periphery is the most anterior, and lesion which is seen in the center is the most posterior. And it is also important to examine the retina standing 180 degree away from the part of the retina being seen. So suppose if we are examining the temporal retina, then we should stand on the nasal side of that eye and vice versa. So this patient is having a supratemporal, the quality of the diagram is not good, but just for depiction, this patient is having supratemporal horseshoe shape here, which you can see here, and a lattice in the supranasal quadrant. So it will be seen in the drawn in the chart like depicted here. So the lattice will come in this quadrant and the horseshoe shape here will come in this quadrant. Like here, it has to be drawn because the horseshoe shape here can be seen in the center of the lens, so it will be drawn in near the equator, and the lattice is seen more peripherally, so it will be coming between the first circle and the second circle. One thing to remember here is that we should draw the mirror image, not exactly the same thing. With this brief in mind, and more so, this will be dealt by Dr. Sangeet Mittal for utilizing it in preoperative planning and all. So I'll be coming to color coding, which is important part of any retinal diagram. So basically, we should remember that red stands for attached retina and the retinal arteries and hemorrhages. Blue stands for detached retina and retinal veins and edema. Green is anything in vitreous, so like vitreous hemorrhage and media opacities. Yellow is for exudates like retinal and choroidal exudates. Brown is for choroidal detachments and pigmented lesions. So these are the various pathologies which can be depicted as drawn. Shall be discussing subsequently. The solid red is used for denoting pathologies like vascular tumor can be drawn like this. dot and blot hemorrhages in diabetic retinopathy can be drawn as drawn here. The subhighlight hemorrhage can be drawn like a boat-shaped hemorrhage. The vortex vein can be drawn like this. A horseshoe tape can be drawn in horseshoe with a solid red and outlines of blue. A simple retinal hole can be drawn as solid red with blue outline. And schisis, if it has got outer layer hole, then we can just draw like a normal hole as described, whereas the inner retinal layer hole can be described as red linings with blue outlines. Now coming to blue solid, the retinal detachment can be drawn in whichever quadrant it is and it is drawn in solid blue. If it is an exudative detachment, then we can denote the sifting fluid with discontinuous lines. And the lattice is drawn with blue hatchings with the blue boundaries. So, and the flat neovaspiration can be drawn as this reason. Coming to green, the asteroids can be drawn as small green dots. The PVD, whether it's incomplete or complete, can be drawn as semicircle or circle. And the vitreous hemorrhage can be drawn like these zigzag lines. The IOL, if present in the vitreous, can be drawn in the shape of an IOL. And the vitreous substitutes can be drawn in near to the circle representing ora serrata all around. Coming to the brown color, this is PET, which is drawn as a small circle in the macula, and this is the old brown pigments in the detached retina. This is the pars plana cyst. So rarely we draw something here, but if it's pars plana cyst is present, we can draw in this between the second and the third circle, and this we can draw like this for a choroidal tumor. And this is choroidal mound, which is choroidal detachment, which is drawn as a dome-shaped elevation. Now coming to yellow, the hard exudates present in various diseases like branch-threaded macular occlusion or diabetic macular edema can be drawn like the small dots, and fresh laser marks are drawn like this as surrounding the horseshoe tear or this lesion. And the long ciliary nerves are drawn like a small radial, a small horizontal lines, and this is nothing but the retinal edema. The black solid colors are used to denote the hyperpigmentation or the seeded vessels, like you normally draw a vessel and then just cross it like these lines. And then in case of chronic RD, we draw demarcation like line like this, so it denotes that it's an old RD. And in attached retina also, we can draw a buccal indentation with the help of a black color. Now coming to various real life scenarios, like these fundus photos, this patient is having right eye central photoretinopathy, and he's having neurosensory detachment. So this will be drawn like this is optic nerve head, and this is the neurosensory detachment. This patient is having right eye supratemporal branch retinal vein occlusion, so it will be drawn like this. This has been drawn on computer, so it's not very accurate, but I have tried to make it look almost accurate. So this is macular edema, and these are the various hemorrhages and the hard exudates. And this patient fortunately presented to us within 1 hour of presentation, and this patient has got central retinal artery occlusion with typical chirated spots and surrounding retinal edema. And this patient could regain vision of 6/6, very fortunate. So this can be drawn like a retinal edema with chirated spot in the center. This patient is having temporal retinal detachment. The hole is not very well seen here, but on indirect ophthalmoscopy, it was there in supratemporal quadrant. So it can be drawn, the detachment can be drawn like this. This configuration is not very popular, I'm sorry, not popular. This is not very well marketed because of the drawing with the computer, but a hole which was present in supratemporal quadrant at 10 o'clock meridian can be drawn like this.
Sorry to interrupt you, doctor. I would request you to cut session.
Yeah. And this patient is having cystoid macular edema. So we can see here on the FFA, the patelloid leak. And this patient, the cystoid macular edema can be drawn like radial spokes. And this patient is having PDR. So the various retinal exudates, the preretinal and the vitreous hemorrhage and the fibrosis can be drawn like this. So the take-home message is that fundus photograph is very important in our retinal examination, and it helps our teammates and gives us a chance to depict the pathology in a very lucid manner, and it helps us in managing the patient further better. Thank you.